Ana Paula Simões, presidente da SPAMDE, está aqui, da Sociedade Paulista também. Ricardo, vou deixar você fazer as honras de apresentar, e aí depois eu posso conduzir os agradecimentos e as questões. Boa noite para todos. Eu só vou deixar aqui, eu vou representar o Ricardo, que vai apresentar a doutora Ana. A palestra vai ser em inglês. Eu vou anotar aqui as questões para poder conduzir a discussão depois, no final. E qualquer dúvida vocês mandem aqui pelo chat, tá bom? Essa é uma parceria da Sociedade do Rio de Janeiro e da Sociedade Paulista de Medicina, Exercício do Esporte, e estamos hoje com uma autoridade em endocrinologia esportiva, que é a doutora Ana Cintrón. Então, vou apresentar para vocês uma outra autoridade em endocrinologia e em medicina do esporte, que é o Dr. Ricardo Oliveira. Please, Dr. Ricardo.
Obrigado, Peralta. Obrigado pela sua gentileza. Peralta é um amigo querido. E queria agradecer a todos que estão assistindo aqui ao nosso evento. First of all, I'd like to introduce Dr. Ana Cintrón. Dr. Ana is one of the most experts in the field of sports medicine. She has been speaking a lot of international congress, including the World Congress of Sports Medicine last year. And this evening, she's gonna talk for us about REDS, Relative Energy Deficiency in Sports. And of course, we are going to listen very carefully. And Dr. Ana, please, go ahead. Thanks for, it's a pleasure having you here.
It's a pleasure for me. I want to thank the Exercise and Sports Medicine Society of Rio de Janeiro and São Paulo. It's an honor for me to be here, to have the opportunity to share with you, even if it's virtually, but it's very good to be with friends. I will speak on the relative energy deficiency in sports and how it has evolutionized from the female athlete triad to RED-S. I have nothing to disclose. And among the objectives, we will be speaking on the timeline, some of the most important related pathologies, the risk factors, diagnosis, treatment, return to play, and prevention. So I think it's always important to look back at the history. And if we review the history of women participation in sports, we can see that the first participation in Olympics was in the 1900, the modern Olympics in Paris, where they participated in tennis and golf. In the photo, you can see Charlotte Cooper, one of the British pioneer females. And throughout the years, female participation continued to increase, but there were several turning points in those years. One of them in the United States was the legislation of a law called the Title IX law. And with this law, it made each educational institution that received federal funding to provide equal opportunity of sports to women. So some similar movement occurred in the European Union with the European Charter for Women's Rights. That occurred in 1987, and both of them, with them, there was as well as worldwide, there was an increase in the participation of females in sports. And here you can see how in the United States, in 30 years, the participation of sports in females, both in high school and in college, increased 5 times more, and it was a movement that occurred worldwide. So with this increase in participation of females in sport came an increase in conditions in female athletes that had not been seen before. One of the cases that brought much attention, especially in the United States, was the case of the gymnast Christy Henrik, who participated in the 1988 Olympic trials for the United States. She did not make the Olympics, but she was told, unfortunately, by a judge that she would never make the Olympics if she did not lose weight. So she started a battle with disordered eating, and in 1991, she was forced to retire, and 3 years after, she died from multiple organ failure. So there were seen similar cases of females which were noticed to have a decreased performance, and many times related or associated to bone problems like stress fractures and menstrual problems. So in 1992, the American College of Sports Medicine convened a group of experts in female health. And in 1993, the female athlete triad was defined. That definition was reviewed 10 years after, and the Female Athlete Triad Coalition, a group of experts in female health and studying this condition, was formed. So the original female athlete triad was described as a disordered eating, most likely anorexia, causing or the direct cause of amenorrhea and osteoporosis. However, throughout the years, it was clear that it was not necessarily a disordered eating, but it was probably an imbalance of the energy available for all the normal physiological functions. And this was the energy deficiency. This was the different definition. So they described it as a spectrum, as you can see here. And one end, it was optimum health, which is the green triangle. And on the other end, you can see the most severe manifestation with low energy availability, with or without eating disorder, causing functional hypothalamic amenorrhea or loss of menstruation, and osteoporosis. But it could be manifested in any part of this spectrum, and many times subclinical, and many times not being able to identify these early symptoms. So it was very clear that these symptoms and this condition was causing significant morbidity and mortality in females, especially in the younger females who were in their growth spurt and producing their bone, their peak bone mass. And it was also clear that maybe the full impact of the syndrome would not be realized until that person, especially the female, reached the menopause. It became alarming that almost 80% of high school athletes had one or more components of the female athlete triad, and in elite athletes, 4% at least of the elite athletes had all three components, which was very alarming. So at that time, and still, many providers in the medical community fail to recognize, sometimes deny, and even underreport some of these symptoms which were initially seen and described as the female athlete triad. So in 2014, an important point or turning point, the International Olympic Committee convened another group of experts, and this is when the red S, or the relative energy deficiency in sport, was defined. And this is the original consensus statement, where they explained very clearly that this energy deficiency was related not only to the reproductive and bone systems, but it affected many or most of the physiological functions in the body. So the other difference was that it occurred not only in females, but also in males, both with the common denominator of a low energy availability. So here is the original diagram where you can see all the physiological systems, the body systems, and you can see in a corner that the triad is only just one part of all of these physiological adaptations to the low energy efficiency, availability, and all because of a mismatch between the energy intake and the energy that is spent. Not necessarily because of a disordered eating. That's one important concept. Of the most important organ systems that were affected, the cardiovascular system with an increase in lipids, early signs of atherosclerosis, arrhythmias, hypotension. In the immunological system, an increase in the risk for infections, especially the upper respiratory tract infections, and most commonly seen in the female. The endocrine system, with an interruption of the hypothalamic pituitary gonadal axis with all the reproductive suppression, which we will speak a little bit more later. The hematological, with decreased iron and ferritin causing anemia. And metabolic. Metabolic, decreasing the resting metabolic rates with a decrease in most of the anabolic hormones. Altogether, all these physiological changes causing a decrease in athletic performance, which is many times the first sign that something is wrong with that particular athlete. So there was a group of authors that challenged the definition of the relative energy deficiency in sports, claiming that elevating all of the physiological changes described here to the same level of the female athlete triad was not appropriate, because the female is at major risk, has a major risk, and has more severe consequences because of energy deficiency. However, throughout the years, it has been clear that even though many issues are different for the male athlete, they are of concern and they are important. They have been important to increase research on the effects of energy deficiency on the male. So it was clear that the Female Athlete Coalition acknowledged the importance and concern for males. They changed their name from the Female Coalition to the Female Male Athlete Coalition. And recently, I mean, in 2020, they published a consensus statement on the male athlete triad, specifically concentrating on the reproductive suppression and on the bone system. So this is the representation of the triad by the coalition, where a decrease in energy availability will produce reproductive suppression and low bone mineral density, and which can be translated to bone stress injuries and stress fractures. So when we speak about the main characteristics of energy deficiency in males, it has been shown that males require a more profound loss of energy to start producing symptoms of energy deficiency when it is compared with females. When the reproductive system is affected, it's recognized as the exercise hypogonadal male condition, where there is a decrease in the testosterone levels and causing a decrease in libido, decrease in sperm count, fatigue, and many other related symptoms. The other difference from males to females is that they are more resilient. They recover much faster, both in bone mineral density as well as in the reproductive system. So they recover the hypothalamic pituitary gonadal axis much faster than what occurs in the female population. So how do we measure energy availability? So there is a measurement, which is the energy availability index, which is the lean body mass or fat-free mass per day, which is equal to the energy intake plus the energy minus the energy that we spend over lean body mass. And it has been described as 45 kilocalories per kilogram of lean body mass per day for normal for females, and below 30 kilocalories per kilogram, it has been shown that negative effects, physiological effects on the reproductive system start in the female athlete or in the female. So 30 kilocalories is not considered a specific threshold because it may be higher or it may be lower, but it is considered an important number. In the males, there has not been a threshold identified either, but when it reaches 20 to 25 kilocalories per kilogram, that is when it has been seen through research that physiological changes, negative physiological changes, start in the male athlete. So we not necessarily are able to make the measurements, and actually it's very difficult to predict which is the optimum energy availability in athletes, because it will change depending on the training, the timeliness of training and competition. And this is why there are so many discrepancies on the optimum energy availability. But we do have indicators that show us or tell us clinically that this athlete has low energy available. One of them is the low body mass index, or BMI. When we have a lower than 17.5 kilogram by square meters for both females and males above 20 years old, this is an indication that there is low energy available. Lower than 20 years old, it has to be adjusted for age and gender. Also, when an adolescent has a weight less than 85% of what is expected for that age and frame. Also, loss of more than 10% weight in 1 month or less is considered low energy. And there are other physiological signs that will demonstrate that there has been a chronic energy deficiency, such as a decrease in anabolic hormones, such as thyroid hormone and leptin. So who are the athletes who are at risk for developing the red S, or the energy deficiency? First of all, those who participate in sports where leanness is very much an important component. Those that participate in sports that have weight categories, and those they are in short span of time trying to make weight, so lose weight in a very short span of time. And those that participate in high endurance sports, and many times increase their energy, their exercise intensity, not necessarily increasing their intake of nutrition. And these are the ones that then fall short of sufficient energy. So when we look at the females, we see the females that are at risk because of the leanness, which is predominant, like the runners, long distance runners, dancers, and the ones that are weight categories, such as combat sports. And we see rowing, which is also a weight category. So in male athletes, we see very similar characteristics. It has been found in sports in which a low body weight provides a performance advantage. And in many sports, there has been identified low weights, and these are the most common: the combat sports, which are weight categories, rowers, long distance runners, and there is an article complete on East African marathon runners describing a low energy availability, road cyclists, ski jumpers, and jockeys. So, and in many of these sports, there is has also been described disordered eating, and the highest has been in cycling, with an incidence of 50%, which is very high. Ski jumpers 24%, and in combat sports 18%. So in many of these as well, what is seen is a decrease in the resting metabolic rate, sometimes by almost 8%, and that is an important fact that shows that the body is trying to maintain lower metabolic functions in order to conserve energy. So what about para-athletes? When we think about para-athletes, they are actually more at risk to develop energy deficiency. However, there are very few research investigation about the para-athlete, and sometimes even the impairment may be one of the causes of having low energy, sometimes because of impaired nutrition. We have wheelchair athletes who, just by being non-weight bearing, they are at risk of having a low bone density. So if you add a decreased intake and a high energy demand in their sports, then they are at very high risk. So, and many of those who are at high risk are those that participate in weight categories, such as para taekwondo, powerlifting, and para judo. So there are also categories which or sports where there are not weight categories, but having a lower weight gives them an advantage in their performance, such as we can see in the picture, wheelchair racing. As if they have lower weight, it will give them an advantage. So many of these athletes are seen with low body weights. And we have, of course, there has to be more research on the para-athlete population. Some of the additional risk factors, first of all, early sport-specific training, pressure from the coaches, pressure from parents, to optimize the performance, to do the best they can, to lose weight, especially by coaches. There are some personality traits who make them also at risk, such as obsessive compulsiveness, perfectionism, high achievers, and also inappropriate coaching, which can be also an important factor, and also psychological factors, but many, probably among the most, is low self-esteem, which is definitely one of the recognized risk factors for energy deficiency. So what is our role as health professionals? We as physical therapists, as athletic trainers, as physicians, will probably be the first ones to have a contact with an athlete that has an energy deficiency. Why? Because they're looking for help because they have most likely an injury. So if we see an injury like this one that we see on the right, a evident stress fracture, this should be a very, very high red flag. And it is very important to start a detailed history, mostly on the dietary history, the stressors, if there have been training changes, especially sudden increase in intensity, the presence of previous injuries, which may show us that this has been there for a longer time. And also in females, the menstrual history, and in males, all the symptoms that are related to hypogonadism. So how do we diagnose this condition? Well, there are several tables which have been prepared by both the Red S group and the female athlete group, and they're actually risk stratification tables, specifically with all of the symptomatology, which includes the presence of disordered eating, bone mineral density, and all of the ones that we have mentioned. And with those tables, then the diagnosis can be suspected. One of the most important tools that we have to early detect one of the symptoms or any of the components of the energy deficiency is the pre-participation exam. It's very, very important, both previous to starting a season and previous before competition. So here is the two examples. This is the Red S cat, and the one on the right is for the female athlete triad, which has been modified for the male, what is recognized as a male athlete triad. We can't discuss it in detail because of the time, but these are very usable tools in order to check and see how our athlete is in terms of risk and the possible diagnosis of Red S or energy deficiency. In our exam, in our physical exam, it is important to look at and look for the red flags. One of the important ones, low BMI, less than 17.5, as we mentioned, weight loss, acute weight loss, orthostatic hypotension, hair loss or lanugo, and we have to look for signs of disordered eating, such as parotid gland swelling, as we can see on the upper right, Russell signs, which are the red signs, it's callus from induced vomiting. This is, of course, in disordered eating. Hyperkeratonemia, which is the yellowish skin. All of these are signs of a possible disordered eating. And we also have to look for, first of all, a decrease in performance, as we mentioned earlier, mood changes, depression, loss of concentration, and loss of the interest in the sport, many times because of that low energy availability. So when the reproductive system is affected in the female, the most common sign is menstrual dysfunction, and the most common sign is the loss of the menstrual cycle for 90 days, which is the definition of amenorrhea. The prevalence is high. It's from 20 to up to 66% in athletes, most common in runners and in dancers. And it's important to realize that for many coaches and for many athletes, losing their menstruation is very convenient, especially for the female. And for coaches, sometimes the message that they give to the athletes is that it is a good sign. It is a good sign of training, and it is a sign of strong training. And these are myths that we have to educate our athletes and let them know, and coaches, and let them know that this is not correct. In the male, we spoke about the exercise hypogonadal male reproductive system. We know that the serum testosterone is low, and they present with the symptoms associated, which are fatigue, decreased libido, decreased sperm count, and if it persists, then it will end in the low bone mineral density. And all of this reproductive suppression has to do with the hypothalamic pituitary gonadal axis, which we can see here, which produces luteinizing hormone and follicle stimulating hormone, that when energy is not available, then they are not produced. And in the female, it will decrease the production of estrogen and progesterone, and cause the functional hypothalamic amenorrhea, which, if persists, will end up with a decrease in the bone mineral density. In the male, a decrease in the pulsability of the LH, or luteinizing hormone. There is a decrease in the testosterone, and we know that testosterone aromatizes in estradiol, and estradiol is one of the important hormones for bone mineral density. So if persists, it will also end with a lower bone mineral density. So important mineral facts, bone mineral facts. We have to take into account that young girls produce their peak bone mineral density at puberty, and in the males it's much higher, sometimes at the end of the their second decade and third decade. But it is important to recognize and identify early the presence of energy deficiency, so that this peak bone density is not affected earlier on in their age. When females have amenorrhea, the greatest bone loss is in that first year. And if it persists, they will lose from 2 to 3% of bone mineral density per year, which is very high. And the prevalence of low bone mineral density in all female athletes has been calculated from 10 to 21%. And studies have shown that if the female recovers the menstruation and recovers the weight, then it has been shown that bone mineral density can increase from a 1 to a 10%. And if the menstruation is not recovered, then it is very low probability that bone mineral density will recover. So this is that is why it's so important to identify it very early on. When do we check densitometry or DEXA? In females, it should be considered when she has at least from 6 to 12 months of amenorrhea or loss of the menstrual cycle, and in females or males, if they have any kind of bone stress injury, stress fracture, then we have to look at the bone mineral density. This is an article which I wanted to share. This is the description of the most high-risk sports in males that have relative energy deficiency. And it is an excellent article because it describes and it makes you realize how it is important to know the characteristics of how the energy deficiency develops in each of these sports, which may be completely different. And that is what helps to develop strategies to prevent the energy deficiency in these athletes. So they describe many of the sports, but just to mention 3 of them. In cyclists, it's very typical and it's a culture of having very lean body mass. And the primary feature is poor bone health. They can lose up to 1.5% of bone mineral density just in one cycling season. So one of the issues or facts that aggravates cyclists, especially road cyclists, is that they are non-weight bearing. So just the fact that they're not weight bearing makes them high risk. And if the energy is low, well, that makes it all the more higher the risk. In combat sports, it's different. Like cycling is an endurance sport. This is a sport in which the weight loss is usually in a very short time. They can lose up to more than 10% of their body weight in just 24 hours just to make weight. So this is important because even though the low energy deficiency is in a short period of time, if it is frequent, it can end with the same consequences as in endurance sports. In jockeys, they are very particular athletes. Jockeys also are weighed before races. And the important thing is, for example, combat sports, after their weight, they start eating again. They are permitted to eat, not so for jockeys. Jockeys, then it is known the action of flipping. Flipping is known in jockeys of induced vomiting after or before being weighed. So that they can make the weight. And in the case of jockeys, the when the bone mineral density is lower, it's of more concern because it has been described that a jockey out of 12 rides, it has an average of 1 fall for each 12 rides. And in this case, if they have a low bone mineral density, they are at a very high risk for traumatic fractures. So this is a particular sport which has its particular characteristics, which we have to identify to prevent the energy deficiency. So how do we treat energy deficiency? It's non-pharmacological is the most important treatment. And the main purpose or goal is to make the balance, the energy balance. And it has to be a multidisciplinary approach, not only the physician, but the sports nutritionist, which is very important, but also all the rest of the multidisciplinary team, therapists, athletic trainers, sports physiologists, all have an important role, and psychologists, of course. And it has, with the sports nutritionist, it is important that these athletes have a proper nutrition for the amount of exercise that they do during their sports. So not always the athlete has to be taken out of exercise. It is recommended that when they have cardiovascular consequences, that then they should be taken out of the exercise, but exercise levels can be decreased always if energy has become balanced. So with also with severe cases, written contracts are recommended, just to make sure and make clear to the athlete what will be the criteria for them to return to participating in their sports if they have to be taken out. Sometimes pharmacological treatment has to be used. In menstrual disorders, oral contraceptives are not recommended. Hormone replacement has actually not been found to increase energy index, and contraceptives will inhibit androgenic hormones, which are very important for bone formation. And in young ones, it may cause premature closure of growth plates. So what has been found that can help both for the menstrual cycle and bone mineral density is the use of transdermal estradiol with cyclic progesterone. And in males, for the bone mineral density, different recommendations. It depends on what source you find. Recombinant or analogs for parathyroid hormone have been used, always if growth plates have been closed. Biphosphonates and testosterone replacement, also clomiphene. Biphosphonates are not recommended for females because they can be teratogenic. So they are only recommended when used for males. Return to play, there is no scientific evidence with specific guides. What both societies, both the ones that describe Red S and the coalition, they all recommend using the same risk stratification tables. And when our athletes are in the lowest risk, that is when they are considered to be ready to return to play if they have been taken out completely, as long as they don't have cardiovascular symptoms. Of course, the ultimate decision or final decision is of the multidisciplinary team with the team physician, and it has to be individualized. Every athlete will be completely different, and every sport will be completely different. Prevention is the key, especially coming from sports organizations like yours. All the sports medicine federations have the responsibility to educate not only parents, athletes, coaches, but also medical providers, because it has been found that up to 50% of health providers who work with athletes cannot identify these signs or symptoms of energy deficiency. So the education has to be to all of them. So it's important to teach on the misconceptions, the myths, especially for females, on the menstruation. And it is important for the sports nutritionist to work with the athletes in order to have a good energy balance. Again, to identify early, pre-participation exam is very important. And if one of the components is identified, then it is very important to look for all the other components through the history or through the physical exam. So in summary, Red S is a syndrome which occurs in physically active girls, females, women, and men, which has multisystemic changes as an adaptation to a low energy deficiency, and of which the female and male athlete is only part of. The low energy deficiency is because there is a mismatch of the energy intake and the energy spent. And some of the physiological changes can reverse, but not all may completely reverse, especially those related to bone mineral density. Treatment is multidisciplinary. It involves medical, nutritional, psychological, and the most important fact, the mainstay is non-pharmacological, and the most important, restore balance in energy. The education is key to all providers, to athletes, coaches, and parents. Important for the prevention, for the recognition and management of this condition. And future research is needed, mostly for males and the para-athletes, in order to know more and how to recognize, and in order to develop strategies to treat, and most of all, to prevent energy deficiency in our athletes. And so I'd like to end with this phrase. This Dr. Barbara Drinkwater is a nutritionist, she died just about a year ago. And she was one of the pioneers of that defined the female athlete triad. And she said that whenever the desire to win is stronger than anything else, we will have problems with sacrificing the well-being of the athlete, whether it's male or female. So she had that vision that not only the female would be affected, but also the male. And with this, I complete my talk. These are my references, and thank you very much.
Well, thank you, Dr. Anna. Congratulations for this remarkable lecture. It was wonderful. I received a few messages here of people really enchanted, with your
thank you
knowledge and your ability to share so much good information. Thank you very much.
Thank you. I wish I could give it in Portuguese, and I've taken some Portuguese classes, but it's still it's not enough.
Problem. You made it perfectly understood. Yeah.
I also would like to thank Dr. Anna for this wonderful talk. So it was a beautiful review of this important topic, especially for me. I am endocrinologist, so we know that we have a lot of endocrinologists in the audience. So thank you very much and congratulations. We have some questions, Fabio, on chat. Maybe we can start, and the second I can make.
Okay. So, Dr. Anna, Dr. Maíta Poli de Araújo, she's a gynecologist. She's congratulating you also here.
Thank you.
And
thank you.
She's asking here, in athletes with low bone mineral density and with amenorrhea, and when we start the estrogen, transdermic estrogen and progesterone orally, what is the time interval to repeat densitometry?
Well, usually what is recommended is about 6 months after treatment, but it can be from 6 months to 1 year, actually. And actually, treatment should be started. It depends on what the source. But many recommend to wait until 1 year before starting treatment, because balancing the energy should alone be enough to restart the cycle. So it depends on the source, but if it were me, in my case, I would try to repeat it from 6 months to 1 year, more or less.
Okay. And she also points out it's a public health situation here, and in her experience, she's telling she has about 30% of Reddits, but they don't have the means to evaluate the thyroid hormone or leptin. Yeah. So if they could, is there a regular interval for that? Since
No,
you can balance it again?
I think that the most important thing is your clinical evaluation more than the hormone levels. The anabolic hormones are known to be decreased, but we don't have to measure these anabolic hormones in order to make the diagnosis or to follow the recovery. I think that what we have to follow, of course, is estrogen levels, as long as we balance the energy. And that's why the emphasis is done so much on the non-pharmacological, because actually it's if you balance, you should be able to recover menstruation. And not necessarily we have to measure these other hormones. We just know, and there is so much literature, and endocrinologists are experts in this. I saw one of Dr. Oliveiro's talks on the male energy deficiency, and it's very complex because almost all of the anabolic hormones are decreased, but they are not necessarily measured in order for us to make the diagnosis. We just know, because it's research, that how much this energy deficiency affects many of the physiological functions. But in terms of clinical, especially when there are not resources, the most important thing is follow the athlete, of course, if possible, with bone mineral density, but the menstruation, that will be one of the most important signs for us that there is going to be recovery. So I hope I answered that question.
Yes, I think so. But Maita Poli was also asking about the possibility of measurement of T3 hormone.
Yeah.
For us endocrinologists, we actually doesn't measure T3 in our clinical practice. Do you think there is any role for the T3, the reverse T3 in these patients? Do you think it could add any value information or not? Just
it will give you information on what's happening, but it won't make any difference in, I believe,
yes,
in terms of the diagnosis.
Yes,
it won't.
Neither for the treatment.
Neither for the treatment, right?
We have a few
Dr.
questions.
Anna. Yes.
Sorry. Can I?
Professor Serafim, please go ahead.
We have a few questions here from Dr. Serafim Borges, which is a good friend of ours. He's a cardiologist, an authority in sports cardiology here. He used to work for the national team and for Flamengo, the best team in the world. And
yes.
he has a few questions here. First of them, he's also congratulating you a lot here. He just loved your presentation. Okay.
Thank you very much. Thank you.
So the first questions here: is the excess of protein ingested by women cyclists hindering the absorption of calcium by the bone a fact or a fallacy in early osteoporosis?
Wow, that would be a question for the endocrinologist. Yeah. I am not sure. I really can't answer that question. I can't answer with certainty. But yes, if maybe Dr. Oliveira can answer that question in terms
Fabio,
of.
Could you repeat the question, Fabio?
Okay, is the excess of protein ingested by women cyclists, female cyclists, hindering the absorption of calcium, of bone calcium? Calcium.
We know that excess of protein intake, it can increase urinary excretion of calcium, but we have a lot of data that up to 1.5, 1.7 grams per kilo per day, it doesn't make any detrimental effect for the bone health. So actually, endurance athletes, they should have a higher level of protein intake because they have a higher muscle metabolism. So we should avoid excess, but they can reach and achieve 1.5 or 1.7 grams per kilo per day. Okay.
There's another question from Dr. Serafin here about endurance sports, right? The adrenal exhaustions of long-term events, right? Does that reduce the athlete's immunity? I think you talked about that in your lecture, putting them at risk for infection.
Stress, I mean, energy deficiency puts them at risk, but just stress can be an important factor in decreasing the immunological system. So yes, of course. Yes.
Usually, I'm just going to put it together here. Is it often in reds to find a low white cell counting?
It has been described, but it's not consistent, not as consistent, but it has been described, and sometimes, especially in the female, and it has been associated to the increase in infections, but it's not consistent. It's not something that has been really consistent found in all females with energy deficiency. So but yes.
Okay. One more question here. Do you believe that beta oxidation, still Dr. Serafin, he's a lot of study here. He loves the theme, okay? Do you believe that beta oxidation of glucose by trimetazidine used in patients with coronary artery disease, does it produce enough energy to punish a 15-year-old athlete with suspension from doping, or something exaggerated?
I'm not sure I understand the question.
Yeah, let me try it again because I'm not sure either. You can have beta oxidation of glucose when you use trimetazidine in patients with a heart condition, with a coronary artery disease. And sometimes it can be used as dope, as you know. So do you think does it justify an advance? Yeah, the use as doping for a young athlete, for example.
Well, you're speaking about the Russian skater, maybe. Yeah. Apparently it does. It seems to have some kind of advantage. I don't know the specifics of that, but now that you mentioned doping, and I'm sorry that I can't give you a more clear explanation on that, but now that you mentioned doping, one of the problems of treating for example energy deficiency in athletes is that the use of testosterone and the use of clomiphene are doping. I mean, it's doping. So if we are going to treat these athletes with this, they have to be completely out of competition because they will be positive for doping. So how much advantage this medication for heart failure can give, I don't know. And actually the case for this case with the Russian skater, it was the first time that I had heard that it was used for doping or for advantage. So I don't think it's something that is commonly used.
Yeah, and there's always there's a problem with doping because they're always ahead of science. We have to chase.
That's correct. That's correct.
Another question.
Fabio, two more questions. So Ana Paula is asking about, Dr. Ana, what do you attribute the absence of pain in stress fractures in athletes? Actually,
the absence of pain?
Yeah. Actually, a lot of athletes complain about pain, but she's asking that some patients, some athletes don't have pain.
He's talking about microfractures, right? Microfractures.
Microfractures, like well, they usually start as periostitis, and then end up as probably a stress fracture. Why they don't, what is usually described is if you have the presence of a stress fracture or early stress fracture, there is no pain after you warm up, but it's because it's probably the adrenaline. It's described as that, but when they cool down, they usually do have pain. And in many athletes, I had an athlete who had a stress fracture, and it was a known stress fracture. It was his last year of competition, and he insisted that he wanted to compete in the intercollegiate races. He was La Barras. A hurdler,
right?
And yes, and he made his trainer. We tried to avoid him to compete. I think that many athletes have a drive so strong to compete that they suppress the pain. And in the case of this athlete, in the not the last hurdle, but the one before the last, when he hit the ground, the bone literally broke. It was one of the worst fractures that I have ever seen, and nobody was able to convince him not to compete. So sometimes I think that drive, psychologically, and it must be physiologically, suppress the pain. What the explanation is, I don't know, but when it is in the early stages of stress fracture or periostitis, stress injury, usually after they warm up, the pain goes away, but it will come back. If it is a serious injury, it will come back when they cool down. So that's at least my experience.
I think there's also a psychological pattern for denial, right?
Yes.
Because they want to compete, that this drive makes them to deny the pain. Maybe they feel some pain, but no, it's okay. Right. So they can be in.
I am strong. I'm gonna try.
Yeah. Yes.
Let me play.
Plus, many coaches will tell you, you can do this, do this and do this, and there was, I never forget, in I think it was the Olympics of Atlanta, that the female gymnasts of the United States won the gold medal, but one of them had a stress fracture, and she competed with a bandage, and she could not walk. For me, that was that she was the hero, she was the heroine, but for me it is negligence, it's abuse of trying to make this or let her compete, so that she has finally a final fracture. With the athlete that we had, the male athlete, there was no way that we could make him not compete, and the coach just backed him up. So we just waited for him, and actually he had this very bad fracture.
You even mentioned about the death of a young athlete, right, in 94.
Yes.
With that drive,
with that drive.
Mm-hmm. We have two. Yeah, that's it. Ana Paula is the president of the São Paulo Medicine Sports Society. She's thanking you here. There's another short question here. How can we assess REDS in menopausal women? Of course, she's not talking about professional athletes. And now I was going to ask you further about this, because we have also amateur athletes. Everybody in different ages wants to take part in in sports events and do endurance
Yes.
competitions and everything. How would you assess it?
Well, it's more difficult in menopausal females because you would have to have a baseline of bone mineral density in order to know if there is an increased bone mineral density, because they're not going to lose their menstruation because they're already in the menopause. So if you don't, then it would be probably with other symptomatic, other symptoms. But you would really, in order to know a decreased performance, fatigue, and of course, if there were a baseline densitometry or bone mineral density, then you would be able to compare. But if not, it's just suspecting because of all the other symptoms that you can have. But you won't have the menstruation, and but you will have the decreased performance and the signs, the symptoms of decreased maybe not only the decreased performance, but the feeling that they're not feeling well symptomatically. But it's more difficult. Definitely, it's much more difficult. And of course, the history, looking for their dietary history, seeing how they are, how their nutrition is, and if it does compensate for the amount of exercise that they're doing. So I think it's a much more complex diagnosis to make. But I don't think it's very so common in menopausal.
Yes.
Yeah,
it's
maybe
that common.
As a baseline in a routine with gynecologists, you should have a bone densitometry in menopausal women to set a baseline, right? I think it would be a nice strategy. And of course, we should stimulate sports in every age. So maybe it would be a nice strategy. One last question here from Pedro Loureiro Porto, also applauding you here, a great lecture. The use of oral contraceptive is not recommended as a primary treatment for the menstrual irregularities in REDS, okay? But should it not be discouraged regarding contraception, right? I don't think, I think he's trying to put it when you want to keep it with contraception. I mean, okay, it's not on label to use oral contraceptives, but in case you have to regard this, because of course this is my interpretation, okay? I think if you're recovering from REDS and you start having a period irregularity, right? Because it's not coming straight.
Completely.
So maybe you have a high risk for pregnancy. So I think that's his point, right?
Well, yeah, yes. If it has actually, when they are in oral contraceptives, it's much more difficult to make the diagnosis of REDS because of the estrogen levels, and so that makes it a little bit more difficult. But one does not contradict. I mean, if you need to have the contraceptives, you use them. I mean, the person, the female, has to use them. That would be fine. What it's not recommended is to start using them as treatment for an energy deficiency, because it has been known that it doesn't increase the energy index. And if they're very young, then there is there are negative effects of using the oral contraceptives. But of course, if they have to use them, they use them. But it's much harder to make the diagnosis, and I don't think it's going to affect the overall result if you use the strategies of balancing energy, and which is, again, the most important treatment. Is not the hormone replacement. It's balancing energy, and it will take time. It will take months to return to menstruation. But on the long run, if it is well balanced, it will return. It will return.
I have a short question too. I heard of, I found it interesting from a sports nutritionist talking about two types of REDs, accidental REDs and intentional REDs.
Yes, that's true. Mm-hmm.
Yeah, and I'd like to know what's the impact on the reversibility of this syndrome, whether it's accidental or intentional, or does it have nothing to do with it?
It should be the reversibility should be the same, because when it's accidental, it's because an athlete unknowingly is not taking enough food or nutrition, maybe because of ignorance, because they don't have the knowledge of how much they need, and therefore it's not on purpose. Different from, for example, weight category sports, where they intentionally stop or limit their nutrition because they want to make a weight, or cyclists because they want to have that performance advantage. It maybe the accidental one will not have such a severe case of energy deficiency as the one that's doing it on purpose. But if you balance energy, the reversibility should be similar. It should be similar.
Yeah, maybe the intention, maybe because it has a psychological drive, because they're insisting on it. Maybe this would be a factor to delay the recovery, but I understand physiologically it's not necessarily.
Not necessarily. No, not necessarily.
Okay,
Fabio, may I have one last question?
Okay.
Just to thank you very much, Dr. Ana. It was amazing. We had almost 100 attendants in this webinar, so thank you very much for sharing your experience. My last question was:
pleasure.
Thank you. Do you have an experience about the use of clomiphene in men with RED-S and male hypogonadism related to RED-S in men?
If we use clomiphene,
do you have experience?
I have not personally. I haven't had the personal, but yes, I've heard of some who are used. But again, it's an analog, right? Because of the doping, the same as testosterone. So it's usually recommended. At least most of the research recommend that it's used after 1 year of non-pharmacological treatment that hasn't worked. So, but I personally have not had the clomiphene. I know that in our clinic, it has been used for some cases.
Yes.
But I know that you have. Yes, I know that you have been using. Mm-hmm.
Yes, since I am endocrinologist, we are seeing more and more excess causing RED-S. Excess causing hypogonadism, excess of weight, such as obesity, and excess of exercise. We have been seeing even more and more men from endurance sports. They come to our office complaining about fatigue, complaining about lack of libido, or even erectile dysfunction. So in this case, I have been using clomiphene 50 milligrams a day, or of course they are not athletes who are engaged in doping and anti-doping system, but most of them are, they have other jobs and make a lot of exercise. So I have some experience with the use of clomiphene. As you said, you have to take care about if you are speaking about professional athletes because of doping system.
Yes.
And thank you very much for sharing your experience. And Fabio, please go ahead for the finish of the webinar.
Just ask, because she's one hour behind, so she must be hungry. It's about dinner time for her now. So I'm going to ask everybody to. Well, I'm going to thank everybody, and I'm going to ask everybody to please. I'm going to just ask 2 last questions, okay, that they just sent right now, and I promise I'll finish. I'm not going to abuse, okay, of your times. Thank you so much. Okay,
I'll try to answer.
okay, it's great. People are loving you here. So there's a short question here about your presentation when you said the oral contraceptive is not so indicated, right? But the transdermic is okay. They are trying to understand the difference. This is one question.
That's a very good question, and I've asked that myself. And why it makes a difference, and one is it's because it has been found that the transdermal has helped in increasing the menstruation. Why? That's a question that I can't answer, but it has been found in research. Maybe Dr. Oliveiro can
Maita
find.
Just answered. Maita answered here to our colleagues here. She said that
yes,
the contraceptive. Go ahead.
Because estradiol, it has receptor on the bone. So when they're treating patients in the menopause, we use estradiol, and it protects the bone. The oral contraceptive, it usually contains ethinyl estradiol, which doesn't protect the bone. So it's related to the type of estrogen, you know. But now in Brazil, we have also oral contraceptives, including estradiol. They are more modern, a newer oral contraceptive, but regular oral contraceptive, it usually contains just ethinyl estradiol, which doesn't protect the bone.
Okay.
On contrary of estradiol, which protects the bone.
Okay, this is now the last question, as I promised. This question is from Reinaldo Martins, a dear colleague, a dear friend from Rio de Janeiro. He's a cardiologist, and he's talking here that there's a major concern on the pre-participation assessment, right? With possible potential changes that we can assess in the EKG. And in red, as we know, there are some electrograph, some changes in EKG, right? Are there more frequent changes in EKG that you in your findings? Is there a correlation with a higher cardiovascular risk?
Not necessarily. We don't, in our pre-participation exam, we don't regularly, and that changes from country to country. If you make an EKG as part of the pre-participation exam. So not necessarily, I can't answer that question because we don't regularly do that. We know on the consequences of the energy deficiency. And of course, when we make the pre-participation exam, if the person has had any kind of history or family history of heart disease, or if the person has had any kind of symptomatology, then we send them for an EKG. But not necessarily we do them. So that's not a practice that we do regularly. So that's, you know, I can't answer that question for you.
No problem.
But
okay.
I guess then you also because that's very controversial in terms of doing the EKG before as a pre-participation. Do you in Brazil do always pre-participation EKG?
Yeah, try to do. Yeah, we do EKG a lot here.
Yes.
For pre-participation assessment. Yes.
Okay.
I just never seen anything related to REDS for specifically for EKG changes, major changes. I mean, you know,
but
and of course we have athletes' hearts with remarkable EKG changes. So
yeah,
maybe it's kind of hard to
Okay, but those, you know, those are questions that I will look for more in the literature, because they're really interesting questions, and I wish I could have answered more of them, but that's my experience. Yeah.
Okay. Well,
and
I like
thank
to
you
thank
for the
everybody.
opportunity.
Oh,
Thank
I
you so much.
you so much
Mhm.
for being here with us. I hope we can meet personally someday, as
Yes.
soon as possible.
Yes.
Okay.
Yes.
You should
I'd
all
like
go to Guadalajara. Is the FIMS World Congress in Guadalajara in September. You should all go.
Sure.
Okay.
Yeah, trying to manage that. Okay,
Let's
Ricardo.
try to go there,
September,
Peralta.
September 23rd to 26th, or 24 to 23rd to 26th. It's around that week. It has 4 days. It's a international FIMS World Congress, and it has many interesting themes. So I hope many of you can be able to go there.
I hope it too. I will keep in touch anyway. I have your email. I'm not gonna leave you alone.
Okay.
Yes,
Okay.
yes.
Okay.
Well,
Thank you
so
very
much.
much, Dr. Ana.
Thank
Thank
you.
you.
Obrigado a todo mundo também que participou, tá? Que acompanhou e que fez as perguntas que enriqueceram ainda mais a nossa conversa. Ricardo, um abração para você.
Muito obrigado, Peralta. Excelente condução aí. Obrigado por tudo.
Obrigado a você.
Você fala inglês, fala espanhol, fala português. So, thank you very much,
Fala muita
Peralta.
besteira também.
Obrigado.
Fala nada.
Dr. Ana, obrigado,
Yes.
Dr. Ana.
Thank you
Muchas
very
gracias.
much.
Saludo.
Have a good night.
Thank
you very much.
You too. Bye-bye.
Bye-bye. See you soon. Bye.